Welcome to MediByte. I'm so glad you're here today. As a healthcare professional, I absolutely love breaking down these complex medical topics into explainers that actually make sense. So today, we're jumping right into the medical facts behind a classic, very dramatic movie trope to explain the real-life clinical condition known as Prelabor Rupture of Membranes, or as we call it in the biz, PROM. You know the exact scene I'm talking about, right? A pregnant character is standing in the middle of a grocery store. They suddenly yell, "My water broke," there's this massive gush of fluid, and just total chaos ensues as they sprint to the delivery room. Well, let's step away from Hollywood for a second. We're going to explore what actually happens medically when your water breaks before labor officially begins. It's actually a fascinating, highly monitored clinical event, and understanding it really takes all the fear right out of the equation.
All right, here's our quick roadmap for today's explainer. First, understanding PROM. Second, the risks and complications. Third, diagnosing the rupture. And finally, the treatment timeline.
Okay, section 1, understanding PROM. Let's start with the basics of what this actually means. The clinical definition of PROM is simply the leaking of amniotic fluid from around the fetus at any time before labor has actually started. In a normal, textbook pregnancy, that fluid-filled membrane surrounding the baby ruptures during active labor. But with PROM, the rupture happens before those regular uterine contractions even get going. And honestly, unlike the movies, the actual flow of that fluid varies wildly. Sure, it can be a sudden gush, but a lot of times, it's just a slow, continuous trickle. Either way, the immediate medical advice is literally always the same. Call your doctor or midwife right away. Now, there's a really critical medical distinction we have to make here, and it's all based on exactly when this rupture happens. If it happens at full term, which means 37 weeks or later, that's standard PROM. But if that rupture happens earlier than 37 weeks, we call it preterm PROM. And that completely changes our game plan, because if the rupture is preterm, the delivery is probably going to be preterm too. To really put into perspective how different the body's response is based on the timeline, let's look at the number 24. If you experience a rupture at full term, natural contractions usually kick in on their own within 24 hours. The body just knows it's time. But if that rupture happens preterm, let's say between 32 and 34 weeks, those contractions might not start for 4 days, or honestly, even longer. It's kind of amazing, actually. The body is essentially trying to hold off, using this incredible biological defense mechanism to buy time because the baby just isn't quite ready yet. Moving right along to section 2, the risks and complications. So regardless of whether the rupture is at term or preterm, opening that protective bubble increases the risk of a few specific things. The absolute most pressing is an intra-amniotic infection. That's an infection of the uterus and the membranes holding the baby, which can cause a fever or abdominal pain for the mom. There's also an increased risk of the baby moving into an abnormal position for birth, or something called placental abruption. That's basically when the placenta detaches from the uterine wall entirely too early. But we really have to ask, what if this whole thing happens way before the baby is physically ready to be born? Well, when we're dealing with a premature rupture, our primary concern shifts pretty rapidly. Premature newborns face a unique, severe set of risks because their organs just haven't finished baking yet. They're at a really high risk for major lung problems and breathing difficulties. There's also a significant risk of bleeding in the brain, which can tragically interfere with development and lead to conditions like cerebral palsy. And get this, if the rupture happens extremely early, like less than 24 weeks in, the severe lack of that surrounding amniotic fluid can actually cause the fetus's limbs to become deformed. All right, let's jump to section 3, diagnosing the rupture. The good news here is that the diagnostic process is super straightforward and gentle. First up, the doctor or midwife does a speculum exam to carefully spread the walls of the vagina. This lets them visually check if amniotic fluid is leaking right out of the cervix. But to be absolutely certain, they don't just eyeball it. They'll often take a tiny sample of that fluid, pop it on a microscope slide, or check its pH level. Amniotic fluid has a very specific pH that is totally different from normal vaginal chemistry, so doctors basically become medical detectives here, making this a highly reliable test. Once PROM is officially diagnosed, and assuming the baby is far enough along to survive outside the uterus, the mother is almost always admitted to the hospital. Now, this isn't to cause panic, okay? It's just so we can keep a really close eye on the baby through continuous, reassuring monitoring. Sometimes doctors will even perform an amniocentesis, which is inserting a super thin needle through the abdomen to get a tiny fluid sample, just to check for any hidden signs of infection inside that sac. And that brings us perfectly to section 4, the timeline of treatment. This timeline brilliantly illustrates why we use gestational age as our absolute guiding light in obstetrics. Healthcare teams completely tailor their medical approach based on the week of pregnancy. It's this delicate, constant balancing act, weighing the rising risk of severe infection if we delay delivery against the profound dangers of prematurity if the baby is delivered right this second. Let's look at the biggest dividing line here, the 34-week mark. If the pregnancy is at 34 weeks or more, the general consensus is that the baby's lungs are mature enough to handle the outside world. So to avoid any infection risk, doctors usually just induce labor artificially. But if we're at less than 34 weeks, the goal completely flips. Now the objective is to delay labor as much as safely possible. We're talking strict hospital rest, limited activity, and checking vital signs at least 3 times a day. When we're trying to safely hit the brakes before that 34-week mark, we rely on a very specific toolkit of medications. First, antibiotics. We give those immediately, usually through an IV at first, then as pills, to stop any infections that might trigger labor. Second, if we're sitting between 23 and 34 weeks, we give corticosteroids. These are an absolute game changer because they rapidly help the baby's lungs and organs mature. And finally, if it's less than 32 weeks, we use intravenous magnesium sulfate. This stuff works wonders to significantly reduce the risk of bleeding in the premature baby's brain, which really helps protect against cerebral palsy. In some cases, doctors might also bring in specific medications just to actively slow down the uterine contractions, basically buying precious time for those corticosteroids to work on the lungs. They might use calcium channel blockers, though these can sometimes cause low blood pressure or give the mom a headache. They can also use prostaglandin inhibitors. But, and this is a big rule here, medicine requires precise timing. We strictly avoid prostaglandin inhibitors after the 32nd week, because at that point, they can actually cause heart and kidney problems for the baby. Now, all of those delay tactics hinge on one vital thing: mom and baby staying infection-free. If, at any point during all this monitoring, the mother develops a fever or her pulse rate spikes, which are the earliest signs of a uterine infection, we abandon the delay strategy entirely. Actually, scratch that, it's not just abandoning the strategy, it becomes an active push for delivery. At that point, the safest route for both patients is to induce labor and deliver promptly, no matter the gestational age. So, how has modern medicine changed the game here? Think about it. What used to be, and what the movies still show as, this highly stressful, totally unpredictable emergency is actually, in today's hospitals, a deeply understood, step-by-step clinical process. By using advanced monitoring, targeted antibiotics, steroids, and incredibly specific timeline protocols, healthcare teams literally turn a medical crisis into a controlled environment that protects developing brains and saves lives every single day. Thank you so much for hanging out with me and trusting MediByte for your medical explainers. We're totally dedicated to breaking down these complex health topics so you can feel informed and empowered. If you found this explainer helpful, please hit that like button, share it with anyone who might benefit, and subscribe to our channel. Your support is what lets us keep bringing you clear, evidence-based healthcare insights. It really makes you wonder, as medical tech keeps advancing, how much earlier will we be able to safely protect premature life in the future? Something to think about. Stay curious, stay healthy, and I'll see you in the next explainer.